Gastrointestinal lymphomas * Praveen Ramakrishnan Geetha Kumari, Syed Mujtaba Rizvi 3232 General Principles of Lymphoma Management Diagnosis. Because of the many subtypes of NHL, lymphoma should be diagnosed and categorized accurately by an expert. Sufficient tissue is required for an accurate diagnosis. In the GI tract, this often means multiple endoscopic biopsies. Fine needle aspiration biopsy is not considered sufficient for diagnosis because it only permits analysis of the morphology of individual cells and not an in-depth examination of the background milieu in which those cells reside. The minimal pathologic workup should include light microscopy and immunophenotypic analysis, either by flow cytometry or immunohistochemistry, IHC. Staining for immunoglobulin light chains assists in the documentation of monoclonality when there is a clear-cut light chain restriction, kappa/lambda ratio or lambda/kappa ratio greater than or equal to 10:1, strongly suggesting B-cell lymphoma. Occasionally, molecular genetic analysis by Southern blot testing or PCR assay is indicated to document monoclonal immunoglobulin or T-cell receptor gene rearrangements, or to assess characteristic oncogene rearrangements. One must keep in mind though that clonality markers might be positive in various inflammatory conditions and are not necessarily pathognomonic of a malignancy. Therefore, an evaluation of a biopsy sample by an expert hematopathologist is extremely important to render an accurate diagnosis. Staging and prognostic assessment. The extent of involvement by NHL is assessed by careful history and physical examination, CT of the neck, chest, abdomen, and pelvis, PET in cases of high-grade NHL, bone marrow examination, and EUS for PGILs. 10 Waldierring is often involved in GI lymphomas. An examination of the pharynx is therefore indicated. Prior to the initiation of treatment, serologies for HIV, hepatitis B, and hepatitis C and screening for HP in gastric lymphomas should also be obtained. The Ann Arbor Staging System 11 was originally developed for Hodgkin lymphoma and is also used for NHL, but is deemed by many to be inadequate for staging of PGILs. Alternative systems have been proposed. Table 32.1. Point 12 Prognosis is assessed by defining the distinct lymphoma subtype and evaluating clinical features, including tumor stage, age of the patient, performance status, and serum LDH level. The International Prognostic Index, IPI, is a model used to predict outcome in patients with aggressive NHL. 13 This model has been revised as RIPI to reflect the use of the monoclonal antibody, rituximab, directed against CD20,14 and has been prospectively validated, retaining its predictive value in the rituximab era. Treatment varies according to lymphoma subtype and stage, but it should be noted that the best treatment for many GI lymphomas remains controversial. Whereas many large controlled trials have defined the best treatment for many nodal lymphomas, this is not the case for GI lymphomas. Thus, many treatment recommendations are based on small case series and extrapolation from results with nodal lymphomas. Prior to the initiation of treatment with systemic chemotherapy, interested patients should receive counseling regarding fertility preservation in addition to the side effect profile of drugs being used. 15 We also routinely screen patients for chronic infections such as HIV, HBV, HCV, and HP in lymphomas involving the MALT. We consider this important because a sizable percentage of low-grade lymphomas will undergo spontaneous regression after the chronic infection driving them is adequately treated. Gastric lymphomas. Primary gastric lymphomas account for 5% of gastric neoplasms, with an increasing trend worldwide. 16 The stomach is the most common extranodal site of lymphoma and accounts for 68% to 75% of PGILs. 17 Most of these gastric lymphomas are classified as marginal zone B-cell lymphoma of the MALT type or as diffuse large B-cell lymphoma, DLBCL. 2 Gastric marginal zone B-cell lymphoma of mucosa-associated lymphoid tissue, lymphomas, extranodal marginal zone B-cell lymphoma of MALT, also known as MALT lymphoma, was first described by Isaacson and Spencer in 198,318 and comprises about 8% of all NHLs. 19 These lymphomas arise from malignant transformation of B cells from the marginal zone of MALT. 20 They may arise from MALT that ABTGCBMZ MAR Fig 32.1a, normal mucosa-associated lymphoid tissue of small intestine. The T-zone is situated toward the serosal aspect, T. Intraepithelial B cells are also present, B. Large B-cell lymphoma of the small intestine. Note the infiltration and expansion of the mucosa by the neoplastic cells, with atrophy of the native epithelial structures. GC, germinal center, MAR, pale external marginal zone, MZ, dark surrounding mantle zone. Courtesy of Dr. Pamela Jensen, Dallas, TX. 444 Part 4 Topics involving multiple organs exists under normal physiologic circumstances, e.g., in Peyer's patches of the gut, or from MALT associated with infection or an autoimmune process. For example, gastric tissue normally does not contain MALT but may acquire it in response to chronic HP infection, see Chapter 52. Point 21 The phenomena of lymphocytic homing, which involves interaction between circulating lymphocytes and endothelial venules mediated by lymphocyte integrins and tissue-specific addressins, is key to extranodal lymphomagenesis. Point 22 Malignant transformation occurs in a small percentage of patients with acquired gastric MALT and results in a lymphoma with generally indolent behavior. The malignant process appears to be driven to a large degree by chronic HP infection because eradication of this infection leads to regression of the lymphoma in 50% to 80% of cases. Point 23,24 Epidemiology Gastric marginal zone B-cell lymphoma of MALT represents 38% to 48% of gastric lymphomas. Point 25 The incidence varies according to the incidence of HP in the population being assessed. Thus, the incidence in northeastern Italy, where the rate of HP infection is very high, is roughly 13 times the incidence in the United Kingdom. Point 26 The median age at diagnosis of gastric MALT lymphoma is approximately 60 years, with a wide age range, with men and women affected equally. The male-to-female ratio is equal. Point 27 Cause and pathogenesis HP infection. Several lines of evidence support the key role of HP in the development of gastric MALT lymphoma, see Chapter 52. Infection by HP is present in the vast majority of cases of gastric MALT lymphoma. Point 28 The epidemiologic studies cited earlier have shown a close correlation between the prevalence of HP infection and gastric lymphoma in a given population. 29,30 and case control studies have shown an association between previous HP infection and subsequent development of gastric lymphoma. 31 In vitro studies have shown that gastric MALT lymphoma tissue contains T cells that are specifically reactive to HP. These HP-reactive T cells support the proliferation of neoplastic B cells. 32 Gastric MALT lymphoma can be induced in murine models by chronic Helicobacter infection. 33 Many groups have documented the regression of gastric MALT lymphoma after eradication of HP. Point 23,24 34 Of interest, responses of small intestinal and rectal lymphoma to HP eradication have been reported. 35-36 Although a consistent role of the organism at these non-gastric sites is not clear. Lymphomas have also been reported in patients with Helicobacter pneumoniae infections, with resolution after eradication of the infection. 37 Evidence for antigen-driven B-cell proliferation. As noted previously, the B-cell immunoglobulin variable region, V, genes undergo somatic hypermutation during the T-cell-dependent B-cell response to antigen 4, which leads to the production of new antigen receptors with altered antigen binding affinity. Resultant B-cell clones that express higher affinity antigen receptors have a survival advantage over B-cell clones containing receptors with lower affinity. Thus, somatic mutation is a marker for antigen-driven selection of B-cell clones. Sequence analysis of malignant B cells from gastric MALT lymphoma shows that the immunoglobulin genes have undergone somatic mutation. 38 Genetic studies. There are 4 main chromosomal translocations in extranodal marginal zone lymphomas, T11, 18, Q21, Q21, T14, 18, Q32, Q21, T1, 14, p22, q32, and T, 3, 14, p14.1, q32. The most common translocation, T, 11, 18, q21, q21, is found in 30% of cases, but its incidence varies with disease site. It is more common in cases involving the stomach and lung, but rare in other sites. 39,40 The T, 11, 18, q21, q21, translocation results in the reciprocal fusion of the API2 and MALT1 genes. API2 is an apoptosis inhibitor, and MALT1 is involved in nuclear factor kappa B, NF kappa B, activation. MALT lymphomas with this translocation do not respond as well to antibiotic therapy aimed at eradicating HP infection similar to lymphomas without this infection. 23 However, these lymphomas are also less likely to have other chromosomal translocations or transform to more aggressive large cell lymphomas. 39,41 The T, 14, 18, q32, q21, variant results in the translocation of the MALT1 gene on chromosome 18q21 to the immunoglobulin gene heavy chain enhancer region, leading to its overexpression, thus differing from the T, 14, 18, translocation of FL, which involves the BCL2 gene. The T, 14, 18, q32 q21, translocation occurs in about 20% of MALT lymphomas overall. Although the incidence varies according to the disease site, it is rare in the GI tract but more common in lymphomas occurring in the salivary glands and ocular adnexa. 39 Table 32.1 Staging systems for primary gastrointestinal lymphomas. Stage modified Paris staging system ** TNM staging system, modified for gastric lymphoma, Ann Arbor staging system. Tumor involvement ITI N0 T2 N0 T1 N0 M0 IE. Mucosa, submucosa T2 N0 M0 IE muscularis propria T3 N0 M0 IE serosa 2 extending into abdomen II1 equals local nodal involvement T1-3 N1 M0 IE perigastric or periintestinal lymph nodes II2 equals distant nodal involvement T1-3 N2 M0 IE more distant regional lymph nodes II penetration of serosa to involve adjacent organs or tissues T4 N0 M0 IE invasion of adjacent structures 4 disseminated extranodal involvement or concomitant supradiaphragmatic nodal involvement T1-4 N3 M0 IE lymph nodes on both sides of the diaphragm T1-4 N0-3 M1 IV distant metastases, e.g., bone marrow or additional extranodal sites, * modified from Rusconiformis Strauss A, Drago 6b, Morgner A, ETAL Paris staging system for primary gastrointestinal lymphomas. Gut 2003, 52:912-3. GI, gastrointestinal, TNM, tumor node metastasis. Chapter 32 Gastrointestinal lymphomas 445-32 Approximately 5% of gastric MALT lymphomas have a T, 1, 14, p22, q32, translocation. 42 In this translocation, the BCL10 gene is brought under the control of the immunoglobulin heavy chain gene enhancer, deregulating its expression. This translocation has been detected only in patients with MALT lymphomas, but those with it often have concurrent trisomies of chromosomes 3, 12, and 18. It is more commonly found in advanced stage cases, which are less likely to respond to HP eradication. Finally, the T, 3, 14, p14.1, q32, translocation results in the juxtaposition of the gene for the transcription factor FOXP1 on 3p14.1, next to the immunoglobulin gene heavy chain enhancer region, leading to deregulation of FOXP1, 43 that is necessary for B-cell development. 44 Common molecular pathways from mucosa-associated lymphoid tissue lymphoma chromosomal translocations. The first three translocations listed earlier all activate nuclear factor kappa B, NF kappa B, a transcription factor that increases cell activation, proliferation, and survival. See chapters 1 and 2. 45,46 In unstimulated B and T lymphocytes, NF kappa B is sequestered in the cytoplasm because it is bound to IB, an inhibitory protein. Phosphorylation of Ib targets it for ubiquitination and degradation, thus releasing NF-kappa B, which then translocates to the nucleus to function as a transcription factor. The pathways through which Ib is phosphorylated are tightly regulated and involve BCL10 and MALT1. Excessive BCL10 or MALT1 activity occurring as a consequence of T11, 18, T14, 18, or T1, 14, leads to constitutive NF-kappa B activation. 39 Model for the pathogenesis of gastric mucosa-associated lymphoid tissue lymphoma. A model for the pathogenesis of gastric MALT lymphoma suggests that the evolution of the disease is a multistage process, comprising the sequential development of HP gastritis, low-grade B-cell lymphoma, and then high-grade B-cell lymphoma. 42 This model is supported by gastric biopsies obtained from patients with chronic gastritis taken years before the onset of lymphoma, showing B lymphocytic clones that later gave rise to a clinically evident lymphoma. In this model, HP infection elicits an immune response in which T and B cells are recruited to the gastric mucosa, where MALT is then formed. HP-specific T cells provide growth help to abnormal B cell clones. The abnormal B cells may not be HP-specific and may even be autoreactive. However, their continued proliferation, initially, depends on T cell help. The pivotal role of HP-reactive T cells in driving B cell proliferation may explain why tumor cells tend to remain localized and why the tumor regresses after eradication of HP. However, continued B cell proliferation eventually leads to accumulation of additional genetic abnormalities, resulting in autonomous growth and more aggressive clinical behavior. Because only a small percentage of HP-infected individuals develops lymphoma, additional currently unknown environmental, microbial, or genetic factors must play a contributory role. Genetic polymorphisms affecting genes such as IL-1RN and GSTT1 involved in inflammatory responses and antioxidative capacity may be partly responsible for the genetic background for MALT lymphomagenesis. 47 HP strains expressing certain proteins such as CAG-A and oxidative damage have been suggested to play a role in the development of gastric lymphoma. 48 Pathology, gross appearance and location. Low-grade gastric MALT lymphomas may present as a single lesion or as multiple lesions. Unifocal disease usually presents as ulcerated, protruding, or infiltrating masses, but may also manifest as erosions or simply erythema. They are most commonly located in the antrum. Histology. The key histologic feature of low-grade MALT lymphoma is the presence of lymphoepithelial lesions, Fig. 32.2. 18,49 These lesions are defined as the unequivocal invasion and partial destruction of gastric glands or crypts by tumor cell aggregates. It should be noted, however, that these lesions can sometimes be seen in cases of florid chronic gastritis. Tumor cells are small to medium-sized lymphocytes, with irregularly shaped nuclei and moderately abundant cytoplasm. The morphology of these cells can vary from small lymphoplasmacytoid cells to monocytoid cells that have abundant pale cytoplasm and well-defined borders. 50 Scattered larger cells or transformed lymphoblasts may also be seen. The lymphoma cells infiltrate the lamina propria diffusely and grow around reactive follicles. The germinal centers may be invaded, a phenomenon termed follicular colonization. Because there is a continuous spectrum from the transition of gastritis to lymphoma, diagnosis of borderline cases can be difficult. Various parameters may assist in the distinction, such as the prominence of lymphoepithelial lesions, degree of cytologic atypia, and presence of plasma cells with Dutcher bodies, periodic acid Schiff-positive intranuclear pseudo-inclusions. The presence of large cells can add further complexity to the diagnosis. 16 The low-grade MALT lymphoma may have scattered large cells, but the tumor is composed predominantly of small cells. At the other end of the spectrum, gastric lymphomas that contain only large cells or only small areas of small cell MALT-like lymphoma should be classified as DLBCLs, see later. 5 In between the ends of this spectrum are low-grade lymphomas in the process of evolving into more aggressive lymphoma, with increasing numbers of large cells being observed with transformation. Immunophenotype. Gastric MALT lymphoma cells have the typical immunophenotype of marginal zone B cells. They express pan-B antigens, CD19, CD20, and CD79A, and they lack expression of CD5, CD10, CD23, and cyclin D1.2. Further immunostaining by experienced pathologists can aid in identifying lymphoepithelial lesions, see Fig 32.2, and in distinguishing follicular colonization from FL, a rare occurrence in the stomach, see later. Fig 32.2 photomicrograph showing a lymphoepithelial lesion characteristic of gastric mucosa-associated lymphoid tissue lymphoma. Cytokeratin stain demonstrates invasion and destruction of some gastric glands by a monomorphic population of lymphocytes. Note for comparison the uninvolved normal glands in the bottom center of the photograph. Special stains, not shown, demonstrated HP, courtesy drive. Edward Lee, Washington, D.C. 446 Part 4 Topics involving multiple organs. Molecular tests of monoclonality. Southern blotting or PCR assay of immunoglobulin heavy chain rearrangement can assist in the documentation of monoclonality. It should be noted that B-cell monoclonality may be detected in HP-associated gastritis, see Chapter 52. Although monoclonality may predict for later development of lymphoma, monoclonality alone does not allow a diagnosis of lymphoma. Thus, molecular tests should always be considered in the context of histologic findings. Clinical features. Symptoms, signs, and laboratory tests. The most common symptoms are dyspepsia and epigastric pain. Other less common symptoms include anorexia, weight loss, nausea, and/or vomiting, and early satiety. 42 Gastric bleeding and B symptoms, fevers, night sweats, weight loss, are rare. Serum levels of LDH and beta-2 microglobulin are usually normal. 51 Diagnosis and staging. Patients are evaluated by EGD. PPI therapy should ideally be withheld for at least 2 weeks prior to endoscopy to avoid a false negative result for HP. Endoscopic findings include erythema, erosions, and/or ulcers. Diffuse superficial infiltration is typical for MALT lymphoma, whereas masses are more commonly seen in DLBCL, Fig 32.3, and aggressive NHL. The most common site of involvement in the stomach is the antrum, but biopsies should be taken from all abnormal areas and randomly from each area of the stomach, as well as the duodenum and gastroesophageal junction, because disease is often multifocal. Because some lymphomas infiltrate the submucosa without involving the mucosal membrane, biopsies need to be sufficiently deep and large for histopathologic and immunohistochemical analyses. HP infection should be established by histologic studies, breath test, or fecal antigen testing, see Chapter 52. 52 EUS can determine the depth of infiltration and assess for the presence of enlarged perigastric lymph nodes. 10 Additional staging consists of upper airway examination, CT of the chest, abdomen, and pelvis, bone marrow aspiration and biopsy, and measurement of the serum LDH level. PET is not usually helpful in gastric MALT lymphoma because of low uptake of fluorodeoxyglucose, FDG. 53,54 Staging system and prognostic assessment. In 1994, an international workshop on the staging of GI tract lymphomas proposed the Lugano staging system 55, a modification of the Blackledge system. The Paris staging system, see Table 32.1, is a modification of the TNM system and incorporates the depth of infiltration as well as lymph node involvement based on EUS. 56 Approximately 75% of gastric MALT lymphomas are confined to the stomach, stage I, at diagnosis 42 and behave in a clinically indolent fashion. Thus, prognosis is good for most patients, with overall survival rates of 80% to 95% at 5 years. Prognosis is poor in the rare patient with more advanced disease. Additional features associated with a worse prognosis are deep infiltration of the stomach wall, which is associated with a higher likelihood of regional lymph node involvement 57 and a high percentage of large cells on histologic evaluation. A MALT lymphoma specific prognostic index, MALT-IPI, has been developed and validated with these 3 key parameters: age greater than or equal to 70 years, stage 3 or 4 disease, and an elevated LDH serum level. The 5-year event-free survival rates in the low, intermediate, and high-risk groups per the multi-PI in the studied patient cohort were 70%, 56%, and 29%, respectively. This easily reproducible tool retained utility in both gastric and non-gastric MALT lymphomas and in different treatment strategies used in the study group. 58 Treatment Large, randomized clinical trials have not been performed in MALT lymphoma because of the rarity of the disorder. Therefore, treatment recommendations are based on case series and expert opinion. Witherspoon and colleagues 24 first reported that gastric MALT lymphoma could completely regress by endoscopic, histologic, and molecular criteria after eradication of HP. Numerous studies have confirmed these observations. 59-62 and antibiotics aimed at eradicating HP, see Chapter 52, have become the mainstay of therapy for low-grade gastric MALT lymphoma. Even patients with advanced stages of disease can regress with eradication of HP. However, it is important to recognize that the current literature in this field is less than optimal in several respects. Older studies are limited by insufficient staging procedures and outdated classification systems. Also, none of the reports is a controlled or randomized trial, and long follow-up is lacking. Nevertheless, the current literature is sufficient to suggest that early-stage disease is best managed with a trial of HP-directed antibiotics, Chapter 52, reserving more toxic therapies such as radiation, chemotherapy, or surgery for cases without concomitant HP infection or for those that do not respond to antibiotics, keeping in mind that it may take several months before remission is achieved. Table 32.2 indicates treatment options by stage using the Lugano staging system. Stage I disease. Most patients fall into this category and can be treated with antibiotic therapy aimed at eradication of HP. Any of the treatment regimens discussed in Chapter 52 may be used. Follow-up endoscopy with multiple biopsies should be done 3 to 6 months after the completion of therapy to document clearance of infection and to assess lymphoma regression. 57 Regression of lymphoma, but not necessarily complete regression, is usually evident at this initial post-treatment examination. Patients with persistence of infection should be treated with a second-line antibiotic regimen, see Chapter 52. 63 Histopathology at this initial post-treatment examination can predict ultimate response, with biopsies showing only small foci of lymphoma being predictive. Fig 32.3 Endoscopic appearance of diffuse large B-cell lymphoma of the stomach with multiple umbilicated lesions adjacent to the gastroesophageal junction. One large ulceration is seen just beyond the squamocolumnar junction. Chapter 32 Gastrointestinal Lymphomas 447 32 of subsequent complete regression and biopsies showing diffuse persistent disease predicting a low likelihood of subsequent complete regression. The Witherspoon Index was initially proposed, 1993, as a histologic tool to evaluate therapy response, but its utility has been more for initial diagnosis. The Group d'études des lymphomas de l'adult post-treatment histologic evaluation system, 2003, 64 is an effective, reproducible criteria to monitor therapeutic courses of gastric lymphomas, Table 32.3. Patients are then followed with endoscopy approximately every 6 months for 2 years and then yearly. Overall, approximately 75% of patients with stage I disease confined to the mucosa and submucosa achieve complete remission. 30 The median time to remission is 5 months, with remission usually occurring within 12 months. However, time to remission has been reported to be as long as 45 months. 23,65 of patients in clinical remission, a majority will still have tumor clones detected by PCR. 59 With continued follow-up of these patients, the malignant clone decreases. Current studies have suggested that a positive PCR at histologic remission does not predict subsequent relapse, but longer follow-up of this issue is necessary. Approximately 90% of patients who had a complete clinical remission to HP eradication remain in remission. 30 But late relapses can occur. Relapse may occur in association with HP reinfection and can be cured by eradicating the organism again. In the absence of HP reinfection, Relapse is frequently transient. 66 A randomized trial of patients who responded to HP treatment did not show a benefit with chlorambucil when compared to observation. 67 Approximately 25% of patients do not respond to HP eradication. 68 Lack of response is more common in patients with the T11, 18, Q21, Q21 translocation. In one study, 67% of non-responders harbored this abnormality, whereas only 4% of responders did. 69,70 Lack of response to antibiotic therapy used in HP infection is also seen in HP-negative gastric malt lymphomas 71 and in patients with lymph node involvement at diagnosis. 57 The optimal management of disease unresponsive to HP eradication is not certain. Options include surgical resection, chemotherapy, and radiation. These options are discussed in the section on treatment of stage IIE disease, see later. The management of patients with localized disease but a significant percentage of large cells is also uncertain. More recent studies have documented remission after HP eradication, in contrast to earlier studies. For example, in one study of 34 patients with high-grade histology, 18 had disease regression with HP eradication and were free of lymphoma after a median follow-up of 7.7 years. 72 If this approach is taken, the patient should be followed closely and, if the response is suboptimal, treated with one of the approaches discussed in the following section. As mentioned, occasional cases of gastric malt lymphoma are HP negative and these patients are much less likely to respond to antibiotic treatment. However, anti-HP treatment should still be attempted because of possible false negative results for HP or in the event that another Helicobacter, H. Heilmannii, caused the lymphoma. 57 Locally advanced disease, stage I with involvement of muscularis or serosa or poor response to HP eradication, stage IIE. Patients with more advanced stage disease who are HP positive should also receive antibiotic therapy, but antibiotic therapy alone is usually not sufficient to eradicate the lymphoma. There is currently no consensus regarding the optimal management of this group of patients. Total gastrectomy can cure more than 80% of patients with stage IIE disease but diminishes patients' quality of life and has not been shown to achieve superior results when compared with more conservative approaches. 73 Involved field radiation therapy, 30 to 40 GY delivered in 15 to 20 fractions to the stomach and perigastric nodes, produces excellent results with a complete remission rate of 90% to 100% and a 5-year disease-free survival of approximately 80%. 74,75 Radiation therapy is usually well tolerated and preserves gastric function. Thus, it has become the preferred therapy for patients with advanced stage disease, those who are negative for HP, and those with persistent disease despite HP treatment. 76 Other treatment options in this group include chemotherapy, immunotherapy, combined chemoimmunotherapy or newer novel, target-specific chemotherapeutics such as ibrutinib. Older data suggests that single-agent oral chemotherapy drugs such as cyclophosphamide 23 or chlorambucil have activity, as does treatment with purine analogues such as cladribine, 2-CDA, which may be more effective in patients with T11, 18, Q21, Q21. 77 Chemoimmunotherapy with rituximab, a monoclonal antibody against CD20, in combination with chlorambucil 78,79 fludarabine 80 cladribine 81 and bendamustine 42. An approach similar to treatment of other low-grade BNHL, has shown response rates of 80% to 100% with acceptable toxicity. Table 32.2 Treatment of gastric marginal zone B-cell lymphoma of MALT type * Lugano stage treatment I, with disease limited to mucosa and submucosa antibiotics alone 2, with involvement of muscularis propria or serosa best treatment unknown currently. Radiation or chemotherapy is probably a better option than surgery, see text. 4. With involvement beyond stomach wall chemotherapy for symptomatic disease. Local management with radiation or surgery may be indicated in selected cases * according to Lugano staging system. Patients with HP infection should be treated with antibiotics to clear the infection, regardless of stage, see Chapter 52. Patients with a high percentage of large cells and disease limited to the mucosa may respond to antibiotics alone, although further study of this issue is necessary. Patients with a high percentage of large cells and more advanced stage disease should be treated as in Table 32.4 for diffuse large B-cell lymphoma. MALT, mucosa-associated lymphoid tissue. Table 32.3 Histological evaluation system proposed to evaluate MALT gastric lymphomas following antibiotic therapy, as proposed by the group d'études des lymphomas de l'adulte. Treatment outcome definition histological characteristics CR complete histological remission normal or empty lamina propria and/or fibrosis with absent or sparse plasmacytes and lymphoid cells in the lamina propria without lymphoepithelial lesions PMRD probable minimal residual disease empty lamina propria and/or fibrosis with disease aggregates or lymphocyte nodules in the lamina propria, in the muscularis mucosae, and/or in the submucosa RRD residual disease in regression lamina propria focally empty and/or fibrosis, dense, diffuse, or nodular infiltrated lymphoid, which extends around the glands in the lamina propria. Focal or absent lymphoepithelial lesions NC no change lymphocytic infiltration dense, diffuse, or nodular, +/lymphoepithelial lesions 448 Part 4 Topics involving multiple organs Stage 2 or 4 disease low-grade gastric MALT lymphoma that has spread to distant lymph nodes or extranodal sites should be treated as advanced low-grade B-cell NHL. Various regimens are used, most incorporating rituximab. 82,83 Such disease is usually not considered curable, but is generally indolent, with transient responses to chemotherapy. 84 Asymptomatic patients may be followed expectantly. Diffuse large B-cell lymphoma of the stomach epidemiology approximately 50% of gastric lymphomas are DLBCLs. The incidence may be higher in developing than in developed nations, but clinical features appear to be similar. The median age is approximately 60 years, with a slight male predominance. 17 Cause and pathogenesis. The pathogenesis of gastric DLBCL is poorly understood. Many large cell tumors have components of low-grade MALT tissue and are assumed to have evolved through transformation of low-grade lesions. Frequently, these bear identical rearranged immunoglobulin genes. According to the WHO classification, this is now referred to as diffuse large B-cell lymphoma with areas of marginal zone MALT-type lymphoma. 5 However, other DLBCLs have no evidence of associated low-grade MALT tissue. It is unclear whether de novo gastric DLBCL has a worse prognosis than DLBCL with areas of marginal zone MALT-type lymphoma. 85 If the large cell lesions commonly arise from progression of low-grade lesions, then conceivably HP may have a role in the initial pathogenesis. One study has suggested that HP infection is more common in patients whose large cell lesions had a low-grade component. 86 Also, observation of a response of early-stage large cell lymphomas to HP eradication has suggested a role for the organism, at least in some cases. 72,87 As outlined earlier in the discussion of tentative models for HP-induced lymphoma, large cell transformation resulting from genetic events, including loss of p53 and p16, may lead to tumor cells losing their dependence on HP for growth. 2 A high incidence of somatic mutations in rearranged immunoglobulin heavy chain variable genes in one study of DLBCLs of the stomach has implicated antigen selection in the genesis of the lymphoma. Pathology DLBCL may appear grossly as large ulcers, protruded tumors, see Fig 32.3, or multiple shallow ulcers. 88,89 The most common sites of involvement are the body and antrum of the stomach. Tumors with a low-grade component are more likely to be multifocal than tumors with no low-grade component. Large cell lymphomas typically invade the muscularis propria layer or even more deeply. Microscopic examination reveals compact clusters, confluent aggregates, or sheets of large cells that resemble immunoblasts or centroblasts, most often with a mixture of the two. Fig 32.4.2 From 25% to 40% of cases show evidence of derivation from MALT, including dense infiltration of centrocyte-like cells in the lamina propria and typical lymphoepithelial lesions. 86 Immunophenotypic analysis shows expression of one or more B-cell antigens, CD19, CD20, CD22, CD79A, and CD45. Lesions with evidence of low-grade MALT tissue do not express CD10, consistent with their having evolved from the CD10 negative marginal zone low-grade lesions. Lesions without evidence of MALT may or may not express CD10. Genetic analysis reveals monoclonal immunoglobulin gene rearrangements. BCL6 is frequently mutated or rearranged 90. If this is seen along with translocation involving MYC, the lymphoma is referred to as a double-hit DLBCL, or based on WHO 2016 classification, high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangements. 5 MYC translocation along with rearrangements in either BCL2 or BCL6 are increasingly being recognized as adverse prognostic features, and most experts modify treatments based on it, using more intense chemoimmunotherapy regimens. Similarly, increased expression of MYC and BCL2 by IHC staining is associated with relatively poor outcomes. Although colloquially referred to as double expressor, this category is not formally recognized by WHO yet, and outside of the setting of a clinical trial, most experts continue to use standard R-CHOP for it. It is worth discussing the evolution in terminology regarding DLBCLs of the stomach. Many pathologists have referred to lymphomas arising in MALT with high-grade features, with or without a component of low-grade disease, as high-grade gastric MALT lymphomas. However, those involved in the development of the WHO classification were concerned that many clinicians had come to regard the term gastric MALT lymphoma as synonymous with a lesion that responds to antibiotics. This is usually not the case with high-grade lesions arising in MALT. Therefore, those involved in formulating the WHO classification 5 agreed to use the term extranodal marginal zone B-cell lymphoma of MALT type for low-grade lesions, and the term diffuse large B-cell lymphoma for high-grade lesions, leaving out the term MALT. Low-grade lesions involving MALT often contain varying proportions of large cells, with a worse prognosis in relation to increased percentage of large cells. However, at this point, a precise grading system for this situation has not been devised and remains a goal of ongoing research. Clinical features: patients present with epigastric pain, 70%, or dyspepsia, 30%, symptoms similar to those patients with gastric adenocarcinoma. 88,91 Large tumors may cause obstruction. Ulcerating lesions may be associated with GI bleeding. B symptoms: fevers, night sweats, weight loss, and elevated serum LDH levels are uncommon. Staging consists of EGD, see Fig 32.3, upper airway examination, CT of the chest, abdomen, and pelvis or PET-CT scan, bone marrow aspiration and biopsy, and measurement of the Fig 32.4 photomicrograph showing diffuse large B-cell lymphoma in stomach. There is a dense infiltrate of medium-sized to large lymphoid cells within gastric mucosa. Courtesy Dr. Veena Chen, UT Southwestern Medical Center, Dallas, TX. Chapter 32 Gastrointestinal Lymphomas 449 32 Serum LDH level. In addition, EUS plays an important role in assessing depth of stomach wall involvement. HP infection should be assessed. It is detected in 35% of patients with DLBCL of the stomach and is more common in those with concomitant gastric MALT. 88 Most patients have stage I or II disease by the Ann Arbor staging system. 92 However, as other staging systems have been developed, the use of various systems has made it difficult to compare results of different series. Treatment: the optimal management of DLBCL of the stomach is controversial, but the current consensus recommends chemoimmunotherapy with or without radiotherapy as a replacement for surgery. Table 32.4.88 Traditionally, localized disease was approached with surgery alone or surgery followed by radiation and/or chemotherapy for patients with poor prognostic features. 93 This approach had the advantage of providing diagnostic and staging information and avoided the risk of gastric perforation or bleeding that was believed to result from treatment with chemotherapy or radiation. Approximately 70% of patients with stage I disease are disease-free 5 years after surgery. 94 However, several investigators have questioned the role of surgery in the management of localized gastric DLBCL. They noted that with the availability of endoscopy, surgery was no longer necessary for diagnosis and, with the availability of CT and EUS, surgery was no longer necessary for staging. In addition, the risk of gastric bleeding or perforation during chemotherapy is lower than 5%, and only a few of those who bleed require urgent gastrectomy. 95 Surgery, however, carries a 5% to 10% risk of mortality and is associated with significant morbidity. Thus, chemotherapy and radiation were investigated as alternatives to surgery. Retrospective studies have shown similar outcomes in patients treated with surgery alone versus chemotherapy alone. 17 A prospective study of patients with DLBCL of the stomach who were randomized to surgery, surgery plus radiotherapy, surgery plus chemotherapy, or chemotherapy alone showed improved complete response rates and overall survival for patients who received surgery plus chemotherapy and chemotherapy alone when compared with those who received surgery alone or surgery plus radiotherapy. 96 The German multi-center study GET NHL 01/92 was a prospective non-randomized study of surgery in conjunction with chemotherapy and radiation versus chemotherapy and radiation alone for primary gastric lymphoma in localized stages. Whether the treatment included surgery was left to the discretion of each participating center. There was no difference in survival rate between those who received surgery followed by chemoradiotherapy and those who received chemoradiotherapy alone. 97 These results were confirmed in a subsequent, larger, prospective non-randomized trial, GET NHL 02/96.98 for patients with advanced stage nodal DLBCL. The addition of rituximab, a monoclonal antibody against CD20, to CHOP, cyclophosphamide, doxorubicin hydroxydonorubicin, vincristine oncovin, prednisone, chemotherapy improves overall survival when compared with CHOP alone. 99-102 This combination has also been administered to patients with gastric DLBCL and found to be safe and effective. 103-104 The necessity of radiation therapy in the management of gastric DLBCL is controversial. A small retrospective study of patients with stage I or II primary gastric high-grade DLBCL treated with chemotherapy with or without radiotherapy has shown decreased relapse rates in patients who received consolidative radiotherapy. 95 However, this study included only 21 patients, of whom 3 relapsed, and it is thought that a prospective randomized trial is needed. Thus, standard management of gastric large B-cell lymphoma follows standard management of nodal large B-cell lymphomas. The treatment of localized, stage I or II, nodal large B-cell lymphoma consists of 3 to 6 cycles of combination chemotherapy, typically the CHOP regimen, given with rituximab, with radiation generally given if using abbreviated chemotherapy, 3 cycles instead of 6. 105-106 Experts are increasingly using a more intense regimen, darabuk, rituximab, etoposide, prednisone, vincristine oncovin, cyclophosphamide, doxorubicin hydroxydonorubicin, for patients with double-hit DLBCL or high-grade B-cell lymphoma with MYC/BCL2/BCL6 rearrangement. This regimen is primarily based on retrospective data, which shows increasing numbers of complete remissions achieved with this regimen and patients achieving complete remission having the best chance of long-term disease-free survival. No prospective data comparing the two regimens based on double-hit status of DLBCL is available. Darabuk, however, for garden variety DLBCL does not lead to better outcomes and carries a risk of more prominent side effects based on data from a prospective trial, called BSLASH-Alliance 50303, presented at American Society of Hematology annual meeting in 2016.107. Similarly, increased expression of MYC and BCL2 by IHC staining is associated with relatively poor outcomes. Although colloquially referred to as double expressor, this category is not formally recognized by WHO as yet and, outside of the setting of a clinical trial, most experts continue to use the standard R-CHOP regimen for it. DLBCL patients with evidence of HP infection should be treated, as response of large cell lymphoma has been reported after eradication of HP. 108-109 However, these studies must be considered preliminary, and most patients treated with antibiotics alone have had disease limited to the mucosa, most patients with DLBCL of the stomach have more advanced disease, and antibiotics alone are considered inadequate treatment. For patients with relapsed/refractory DLBCL after failing 2 lines of therapy, including anthracycline-based regimen, chimeric antigen receptor T-cell therapy is an emerging treatment option recently approved by the FDA. Although durable remissions are being seen with this treatment, long-term data on treatment outcomes is being discerned. 110,111 Uncommon gastric lymphomas. B-cell lymphomas other than marginal zone or diffuse large B-cell may involve the stomach uncommonly, e.g., MCL 1%, FL 0.5% to 2%. Gastric lymphomas of T-cell origin have rarely, 1.5 to 4%, been reported. 112-114 Small intestinal lymphomas. Small intestinal lymphomas may be divided into B and T cell tumors and account for 20% to 30% of PGILs. 115 The B cell table. 32.4 Treatment of diffuse large B cell lymphoma of the stomach. Lugano stage treatment. I-CHOP times 3 to 4 cycles and RT plus rituximab 2, II1, II2, IE-CHOP times 3 to 4 cycles and RT and rituximab 4 CHOP times 6 to 8 cycles and RT and rituximab *. According to the Lugano staging system, optimal management of this entity is controversial. However, the developing consensus seems to favor combined chemotherapy and radiation and avoidance of surgery. See text. Cyclophosphamide, doxorubicin hydroxydonorubicin, vincristine oncovin, prednisone. RT, radiotherapy, usually, 30 to 40 GY in 20 to 30 fractions. The suggestion for the addition of rituximab in this setting involves extrapolation of randomized data from nodal diffuse large B-cell lymphoma. 450 Part 4 Topics involving multiple organs. Tumors include immunoproliferative small intestinal disease, IPSID, and various non-IPSID subtypes, including marginal zone B-cell lymphoma of MALT, DLBCL, MCL, FL, and Burkitt lymphoma. Relatively few reports have described the various non-IPSID small intestinal lymphomas, and large series have tended to group together all the lymphoma subtypes when cataloging manifestations and treatment outcomes. 116-118 Given the lack of information about these diseases with regard to their behavior in the intestine, it is probably best to consider them in light of the well-described features of their nodal counterparts. Thus, marginal zone and FLS are regarded as indolent processes, incurable but controllable by chemotherapy, and often associated with a relatively long survival. DLBCLs, MCLs, and Burkitt lymphomas are more aggressive processes, which generally require chemotherapy as part of their management. T-cell lymphomas of the small intestine are usually enteropathy-type intestinal T-cell lymphomas. Other forms of T-cell lymphoma have been rarely reported. Recent reports have suggested the existence of a rare natural killer, NK, cell or NK-type T-cell intestinal lymphoma. 119-122 Marginal zone B-cell lymphoma of MALT-type lymphoma arising in the small intestine may have the characteristics of marginal zone B-cell lymphoma, with the same histologic and immunophenotypic features described earlier for gastric marginal zone B-cell lymphoma. 121-123 However, an association with HP infection has not been documented, although rare responses to antibiotics have been reported. Most cases occur in older patients who present with melena. The disease usually presents as a single annular or exophytic tumor. 124 which may be present anywhere in the small intestine. Disease is usually confined to the intestine or to local nodes. Treatment is generally surgical. Some patients have received chemotherapy, but few data are available regarding regimens and outcome. It should be noted that in nodal marginal zone lymphoma, chemotherapy is usually reserved for patients with symptoms, because the disease is slow-growing and sensitive to chemotherapy, but not curable by it. The 5-year survival rate is approximately 75%. As in gastric marginal zone B-cell lymphoma, the small intestinal variety may have varying components of large cell transformation. This feature probably confers a worse prognosis, but data are scanty. Diffuse large B-cell lymphoma DLBCL of the small intestine is similar to its gastric counterpart in histology and clinical behavior. Patients may present with abdominal pain, weight loss, obstruction, abdominal mass, bleeding, and slash or perforation. The tumor is usually an exophytic or annular lesion. Histologic findings are similar to those described earlier for gastric DLBCL, with some patients having a low-grade component and others having only a large cell component. Approximately half of patients have localized disease, and half have disease spread to regional or distant nodes. Surgery is usually required because of obstruction or perforation. 125 and additional therapy includes anthracycline-containing chemotherapy and the anti-CD20 monoclonal antibody, rituximab. 126 In addition, radiotherapy is sometimes indicated. Prognosis depends on disease stage and patient factors, such as age and performance status. Mantle cell lymphoma (MCL) is a subtype of B-cell NHL. 127 It is a heterogeneous lymphoma in terms of its clinical behavior, with disease in some patients having an indolent course like a low-grade B-NHL and in others an extremely aggressive course akin to high-grade B-cell malignancies. Patients typically present with widespread adenopathy and frequently have bone marrow and extranodal involvement. The GI tract is involved in more than 80% of patients, Fig 32.5, although not all patients with GI involvement are symptomatic. 128 The most common manifestation of GI disease is multiple lymphoma 2 polyposis, in which multiple lymphoid polyps are present in the GI tract. 129,130 The most common site of involvement is the ileocecal region, but any other area may be involved from the stomach to the rectum. Occasionally patients have involvement of all these regions. Fig 32.6, see also. Fig 32.5. Involvement of the GI tract may also occur without the appearance of multiple polyps, and the GI tract as the only site of involvement has been reported. When patients have symptoms related to GI involvement, they usually include pain, obstruction, diarrhea, or hematochezia. It should be noted that multiple lymphoma 2 polyposis can also be seen with other lymphomas, especially marginal zone B-cell lymphomas of MALT and FLS. Microscopically, MCL involves the mucosa and submucosa, and the malignant cells have the appearance of small a(b) the stomach, A, and in the colon, B. Fig 32.5 Endoscopic appearance of mantle cell lymphoma presenting as multiple lymphoma 2 polyposis in Chapter 32. Gastrointestinal lymphomas 451. 32 Atypical lymphocytes, which may surround benign-appearing germinal centers or may efface the lymphoid tissue. The tumor cells express pan-B markers and the T-cell marker CD5. The disease is characterized by T11, 14, Q13, Q32, a translocation that results in rearrangement and overexpression of the BCL1 gene encoding the proto-oncogene cyclin D. 1.131 Patients with obstructive tumor masses require surgical therapy, but the mainstay of treatment is chemoimmunotherapy. Aggressive presentations of MCL are also usually consolidated with an autologous stem cell transplant in first remission after induction chemotherapy followed by maintenance rituximab. 132 Although MCL is initially responsive to chemotherapy, it eventually becomes refractory. Median survival is 3 to 5 years. The Bruton tyrosine kinase inhibitor ibrutinib has been approved for use in refractory or relapsed MCL. 133,134 Follicular lymphoma Follicular B-cell lymphomas of the GI tract are rare. 135 The most common presentation is as an obstructing lesion in the terminal ileum. As noted, patients with this diagnosis may also present with the gross appearance of multiple lymphoma 2 polyposis. Microscopically, most FLS are composed of small cleaved lymphocytes, or centrocytes, Fig 32.7, with a varying admixture of large cells. The disease is characterized by T14, 18, Q24, Q32, a translocation that results in overexpression of the BCL2 gene. 136 Obstructing lesions require surgical management. Chemotherapy and radiation are sometimes indicated for the management of this indolent but incurable disorder. Duodenal type FL, DFL, is a newly recognized entity in the 2016 WHO classification update. Unlike other FLS, DFL is almost always incidentally detected on endoscopy, solitary or multiple nodules, or polypoid lesions, between 1 and 5 mm, diagnosed at a low grade and stage, and stays localized to most commonly the second portion of the duodenum. By gene expression profile and pathogenesis, it appears more closely related to MALT lymphoma than FL due to the excellent prognosis, median survival greater than 12 years, associated with this disorder. Most experts recommend a wait-and-watch strategy to management. 137,138 Burkitt lymphoma. Burkitt lymphoma is a highly aggressive malignancy that in patients who are HIV-negative presents either as an endemic form, observed in Africa, or a sporadic form. 139 In the sporadic form, patients usually present with disease in the abdomen, with involvement of the distal ileum, cecum, and/or mesentery. Burkitt tumor cells are monomorphic, medium-sized cells with round nuclei, multiple nucleoli, and basophilic cytoplasm, Fig. 32.8. The involved lymphoid tissue microscopically has a starry sky appearance caused by numerous benign macrophages that have ingested apoptotic tumor cells. 140 The tumor cells express B-cell-associated antigens and surface immunoglobulin. Most cases have a translocation of the c-Myc gene on chromosome 8. Either to the immunoglobulin heavy chain region on chromosome 14 or to one of the immunoglobulin light chain regions on chromosomes 2 or 22, resulting in a T, 8, 14, T, 2, 8, or T, 8, 22, translocation. 141 Burkitt lymphoma is rapidly fatal without treatment but responds immediately to institution of aggressive chemotherapy. Treatment carries a high risk of tumor lysis syndrome. Cure rates are 50% to 90%, depending on the extent of the disease. 142,143 Immunoproliferative small intestinal disease epidemiology. IPSID, also known as alpha-heavy chain disease and as Mediterranean lymphoma, is confined to certain regions of the world, especially AB. Fig. 32.6 Multiple lymphoma. 2 Polyposis, mantle cell lymphoma. A. Gross specimen showing numerous small polypoid lesions in the cecum. Additional synchronous and metachronous lesions were present or later developed in the ileum and the duodenum, as well as the rectum and sigmoid colon. B. Low-power photomicrograph of ileum shows multiple discrete sites of mucosal and submucosal involvement by lymphoma. 2 Polyposis. Courtesy Dr. Edward Lee, Washington, D.C. Fig. 32.7 Photomicrograph showing follicular lymphoma, World Health Organization Grade 2. Neoplastic lymphoid follicles are evident, involving the wall of the small intestine and effacing the normal architecture, hematoxylin and eosin, low power. Courtesy Dr. Imran Shehab and Dr. Pamela Jensen, Dallas, TX. 452 Part 4 Topics involving multiple organs. North Africa, Israel, and surrounding Middle Eastern and Mediterranean countries. 144 IPSID is seen less often in other areas, including Central and South Africa, India, and East Asia, and South and Central America. A diagnosis in North America or Europe should be questioned, unless the patient has previously lived in an endemic area. The disease occurs in individuals with lower socioeconomic status who live in conditions of poor hygiene and sanitation. 145 The disease generally occurs in the second or third decade of life, although it has been observed in older individuals. The incidence in males and females is equal. Cause and pathogenesis. Several observations suggest that IPSID may be initiated by an infectious agent or agents. 146. 1. An association of the disease with lower socioeconomic status and poor sanitation. 2. A high prevalence of intestinal bacterial overgrowth and parasitosis. 3. A decrease in incidence when living conditions have improved in endemic areas. And 4. A response of early lesions to antibiotic therapy. In addition, it is known that enteric microbiota stimulate IgA-producing cells, and intestinal biopsies from apparently normal individuals from endemic regions have shown an increase in lamina propria lymphocytes and plasma cells, reminiscent of findings in patients with IPSID. An association with Campylobacter jejuni infection has been demonstrated. 147,148 As discussed later, IPSID is associated with the production of an unusual IgA heavy chain protein, called alpha-heavy chain, which is secreted by plasma cells and is detectable in various body fluids. 149,150 The plasma cells, which are the predominant histologic feature in the superficial mucosa, possess surface and cytoplasmic alpha chain protein. Centrocyte-like cells proliferating deeper in the mucosa have mainly cytoplasmic alpha chain protein. It is likely that these centrocyte-like cells, stimulated by microbial antigens, differentiate into the plasma cells that secrete the alpha chain protein characteristic of the disease. Genetic analyses have revealed that cellular proliferations are monoclonal, even in early lesions. 151,152. Thus, it can be proposed that in a way somewhat analogous to HP-associated gastric malt, lymphocytes in intestinal malt may be stimulated by infectious agents, in particular C. jejuni 153, and proliferate in response. The lymphocytic response becomes monoclonal and initially depends on the presence of antigen. However, with time, the malignant cells acquire additional genetic changes, causing them to lose their dependence on antigen persistence. This loss of antigen dependence is associated with the development of more aggressive clinical features. Pathology: gross lesions are generally confined to the proximal small intestine, with adenopathy of adjacent mesenteric nodes. 154. Although some patients have thickening of mucosal folds only, others have a generalized thickening of the bowel wall, discrete masses, nodules, or polypoid lesions. Although grossly only the proximal bowel wall is involved, histologically the disease is characterized by a dense mucosal and submucosal cellular infiltrate that extends continuously throughout the length of the small intestine. Various pathologic staging systems have been proposed. Table 32.5.154,155. In early stage disease, the cellular infiltrate is composed of benign appearing plasma cells or lymphoplasmacytic cells. However, as already noted, various studies assessing immunoglobulin gene rearrangements or light chain restriction have suggested that even the earliest infiltrate is monoclonal. This early infiltrate broadens villi and shortens and separates crypts, but epithelial cells remain intact. A histologic variant, the follicular lymphoid type, has been described in some patients, see Fig. 32.7. This variant features a diffuse involvement of the mucosa, with lymphoid follicle-like structures. As the disease progresses to intermediate and late stages, the villi are further broadened and may become completely effaced, crypts are fewer, and the immunoproliferation extends more deeply. Atypical lymphoid cells infiltrate the benign-appearing plasma cells and lymphoplasmacytic cells. With time, the process evolves into overt lymphoma. Mesenteric lymph nodes are enlarged in early lesions, with preserved architecture, although follicles may be encroached on by a histologically benign-appearing lymphocytic or plasmacytic infiltrate. As the disease progresses, the lymph node may acquire a more dysplastic appearance. Clinical features: patients usually present with diarrhea, colicky, abdominal pain, anorexia, and significant weight loss, with the duration of symptoms from months to years. The diarrhea initially may be intermittent but becomes voluminous and foul-smelling as malabsorption develops. About half of patients have fever. Physical examination reveals evidence of malnutrition, digital clubbing, and peripheral edema. Late physical manifestations are ascites, A/B Fig 32.8. Burkitt lymphoma. A. Diffuse involvement of the small bowel by Burkitt lymphoma. Note infiltration around native glandular structures. B. High power view showing brisk mitotic activity and background macrophages. CD20 immunostaining, not shown, was strongly positive within the tumor population. A. HNE, times 20, B. HNE, times 600. Courtesy Dr. Pamela Jensen, Dallas, TX. Chapter 32 Gastrointestinal Lymphomas 453. 32 Hepatosplenomegaly, an abdominal mass, and peripheral lymphadenopathy. Endoscopy may reveal thickened mucosal folds, nodules, ulcers, or evidence of submucosal infiltration, rendering the intestine immobile, tender, and indistensible. Small bowel barium radiographs show diffuse dilation of the duodenum, jejunum, and proximal ileum, with thickened mucosal folds. Patients are frequently anemic because of vitamin deficiencies, and the erythrocyte sedimentation rate is elevated in 1/3 of cases. The circulating lymphocyte count is low, and measures of humoral and cellular immunity are impaired. Stool examination frequently reveals Giardia lamblia infestation. As noted, C. jejuni has been implicated in a high percentage of patients by PCR assay, DNA sequencing, fluorescence in situ hybridization, and immunohistochemical studies on intestinal biopsy specimens. 153 Serum IgG and IgM levels may be high or low. IgA levels are usually low or undetectable. The characteristic and unique laboratory abnormality is the presence of the alpha chain protein. 156 This 32 to 34 kD protein is a free alpha-1 heavy chain with an internal deletion of the variable, VH, and CH1 regions. It is devoid of light chains and thus corresponds to the Fc portion of the alpha-1 subunit of IgA. The alpha chain protein amino terminal contains sequences that are not homologous to any known immunoglobulin sequence. These changes are often the result of insertions or deletions, usually involving the VHJH and CH2 regions. 147 But the source of inserted genetic material is unknown. The alpha chain production migrates as a broad band within the alpha-2 and beta regions on serum protein electrophoresis. In addition to electrophoresis, the protein can be detected by immunoelectrophoresis or immunoselection, the most sensitive and specific methods. 147 in serum, urine, saliva, or intestinal secretions. Detection of alpha chain protein from these sources is more likely in patients with early disease than in patients with more advanced disease, but, regardless of stage, alpha chain protein can be detected in tissue sections in most cases of IPSID by immunofluorescence or immunoperoxidase staining of plasma or lymphoma cells. 156 It has been postulated that chronic antigenic stimulation of the intestinal IgA secretory apparatus results in the expansion of several plasma cell clones. Eventually, a structural mutation occurs in a particular clone, resulting in an internal deletion of part of the alpha heavy chain. This leads to an inability to make light chains and results in secretion of alpha chain protein rather than intact IgA. 144,147 Diagnosis and staging. Because the more malignant appearing histology may be present only in deeper layers of the intestine, endoscopic biopsy alone is often considered an inadequate evaluation. Staging laparotomy is therefore strongly recommended by some authors to allow full-thickness intestinal biopsy and biopsy of mesenteric lymph nodes. 157 However, some investigators do not routinely perform laparoscopy or laparotomy, instead, upper and lower GI endoscopy, small bowel series, bone marrow biopsies, and fine needle aspiration of enlarged lymph nodes are performed. 158 One of the staging systems may then be applied, see Table 32.5. More advanced disease, poor performance status, and comorbid illnesses portend a worse prognosis. Treatment. Because of the relative rarity of this lymphoma, no large trials investigating therapy have been carried out. 158,159 Patients. Often Table 32.5 Pathologic staging systems for immunoproliferative small intestinal disease. World Health Organization, A. Diffuse, dense, compact, and apparently benign lymphoproliferative mucosal infiltration, I. Pure plasmacytic, 2. Mixed lymphoplasmacytic, B. As in, A. Plus circumscribed immunoblastic lymphoma, in either the intestine and/or mesenteric lymph nodes, C. Diffuse immunoblastic lymphoma with or without demonstrable, apparently benign, lymphoplasmacytic infiltration. Salem et al. 146 Stage 0, benign appearing lymphoplasmacytic mucosal infiltrate, LPI, no evidence of malignancy. Stage I, LPI and malignant lymphoma in either intestine, 2, or mesenteric lymph nodes, in, but not both. Stage 2, LPI and malignant lymphoma in both intestine and mesenteric lymph nodes. Stage 3, involvement of retroperitoneal and/or extra-abdominal lymph nodes. Stage 4, involvement of non-contiguous non-lymphatic tissues unknown or inadequate staging. Gallion et al. 147 Stage small intestine, site I mesenteric lymph nodes, site IIA other abdominal and retroperitoneal lymph nodes, site IIB other lymph nodes, site 3 other sites, site 4 amateur plasmacytic infiltration of lamina propria, with no OR. Limited disorganization of general lymph node architecture, inconstant and variable villus atrophy. Infiltrate in these sites cytologically like that in site IB atypical plasmacytic or lymphoplasmacytic infiltrate, with presence of more or less atypical immunoblast-like cells, extending at least to the submucosa, subtotal or total villus atrophy atypical plasmacytic or lymphoplasmacytic infiltrate, with presence of more or less atypical immunoblast-like cells, total or subtotal obliteration of nodal architecture infiltrate cytologically similar to that in site IC. Lymphoma 2 proliferation invading the whole depth of intestinal wall. Lymphoma 2 proliferation with total obliteration of nodal architecture. Lymphoma 2 proliferation similar to that in site I*. Rare cells may show an immature pattern. Limited and superficial extensions to submucosa may be observed. Modified from fine KD, stone MJ. Alpha heavy chain disease, Mediterranean lymphoma, an immunoproliferative small intestinal disease. A review of clinico-pathological features, pathogenesis, and differential diagnosis. AMJ Gastrointestinal 1999, 94:113952. 454 Part 4 Topics involving multiple organs require intensive nutritional support. 160 Patients with early disease, e.g., Salem stage 0 disease, see Table 32.5, are generally treated with antibiotics for 6 months or more. The two most commonly used regimens are tetracycline alone and a combination of metronidazole and ampicillin. Response rates have ranged from 33% to 71%. 161. In one study, the complete response rate was 71%, with a disease-free survival of 43% at 5 years. 158 In patients who do not significantly improve by 6 months or who do not achieve complete remission by 12 months, or who have advanced disease at presentation, chemotherapy should be given. Most investigators recommend anthracycline-containing regimens such as CHOP. 162,163 For example, one investigator has reported a complete response rate of 67% and a survival of 58% at 3.5 years in patients treated with antibiotics, total parenteral nutrition, and anthracycline-based combination chemotherapy. 163 However, good results have been reported with non-anthracycline-containing regimens as well. In one report, 56% of patients with advanced disease were free of disease at 5 years. 158. Finally, because total abdominal radiotherapy has been used in only a small number of patients, it is difficult to assess its proper role. 164 Enteropathy-associated T-cell lymphoma. Enteropathy-associated T-cell lymphoma, EATL, occurs as a complication of celiac disease, see Chapter 107. 165 Malignant transformation of intraepithelial T cells leads to an aggressive malignancy, causing most patients to die within a few months of diagnosis. 166,167 Treatment of celiac disease with a gluten-free diet may decrease the risk of this malignancy. 168 Epidemiology. EATL is a rare malignancy with an incidence of only 0.016 per 100,000 population, though the overall age-adjusted incidence is increasing. 169 Celiac disease has a prevalence of 0.5% to 1% in the US and Europe. 170,171 and is more common in whites compared with African Americans and Asians. In patients with symptomatic celiac disease, the most common cause of death was NHL. 172 The diagnosis of lymphoma is usually made concomitantly with or shortly after the diagnosis of celiac disease, although the two conditions are commonly diagnosed simultaneously, especially in patients who have a long history of malabsorption. Adherence to a strict gluten-free diet appears to reduce mortality. 173 The median age at diagnosis of EATL is 60 years and the incidence in men and women is equal. 174 Cause and pathogenesis. EATL occurs in patients with adult celiac disease. 175 As discussed in Chapter 107, celiac disease is characterized by a hereditary sensitivity to gluten. 176 Gluten peptides are presented by celiac disease-specific HLA-DQ2 and HLA-DQ8 positive antigen-presenting cells and thus elicit an immune response in which gluten-specific intraepithelial lymphocytes damage intestinal epithelium. Intraepithelial T cells in celiac disease have a normal immunophenotype, CD3+/CD8+, and are polyclonal. 177,178 Malignant transformation of these T cells results in a monoclonal population of intraepithelial T cells that have an abnormal phenotype. 179-182 Monoclonal populations of intraepithelial T cells in celiac mucosa may result in any one of several interrelated processes. 182,183 The first condition is refractory celiac disease, a condition in which patients lose responsiveness to a gluten-free diet. 184 The second condition, ulcerative jejunitis, is characterized by inflammatory jejunal ulcers and unresponsiveness to a gluten-free diet. 185 The third condition is EATL, an aggressive malignancy of the small intestine. 180,181 In patients with any of these three conditions, uninvolved mucosa adjacent to the lesions can contain monoclonal T cells containing the same rearranged T cell receptor genes. 186 In addition, patients with ulcerative jejunitis can subsequently develop EATL, in which the same clone is isolated in the jejunitis and the subsequent lymphoma. Thus, these three conditions have come to be considered to represent a spectrum of disorders mediated by monoclonal intraepithelial T cells. Comparative genomic hybridization studies have shown recurrent chromosomal gains in EATL at chromosomes 9q, 7q, 5q, and 1q and recurrent losses at 8p, 13q, and 9p. A gain at 9q is the most common, seen in 58% of cases examined. 187 Another study has shown that loss of heterozygosity at 9q21 is a frequent finding. 188 In addition, one study has suggested that gain of chromosome 1q may be an early event in lymphomagenesis. 189 Pathology Tumors typically occur in the jejunum but may be seen in other sites of the small intestine. Lymphoma may occur in single or multiple sites. Grossly, the lymphomas commonly appear as ulcerating lesions, with circumferential involvement of the small bowel. Lesions may also appear as nodules, plaques, or strictures, but large masses are uncommon. Mesenteric lymph nodes are often enlarged, either because of tumor involvement or of edema and reactive changes. Distant sites, especially the bone marrow or the liver, are sometimes involved. Histologically, the lymphoma is generally characterized by large, highly pleomorphic cells with numerous, bizarre, multinucleated forms, with an inflammatory background. A minority of patients, 10% to 20%, may have monomorphic medium-sized cells, Fig 32.9. This was previously termed type 2 EATL and is currently called monomorphic epitheliotropic intestinal T-cell lymphoma, MITL, 5 and may occur in the absence of celiac disease. MITL has an increased incidence in Asian and Hispanic populations. Uninvolved mucosa usually has the typical appearance of celiac disease, with villus atrophy, crypt hyperplasia, plasmacytosis in the lamina propria, and an increase in intraepithelial lymphocytes, see Chapter 107. However, the enteropathy may be subtle in some cases, with only an increase in the intraepithelial lymphocytes. According to 62 patients identified to have EATL in the International Peripheral T-Cell Lymphoma Project, immunophenotyping typically shows that the malignant cells are CD3+, Fig 32.9 Photomicrograph of enteropathy type intestinal T-cell lymphoma in a patient with celiac disease. Mesenteric fat of the small bowel wall is involved with a monomorphic population of small to intermediate-sized irregular T lymphocytes. Cells were positive for CD2, CD3, and CD7, and negative for CD5. T-cell gene rearrangement studies were positive, i.e., showed a clonal band indicating a clonal T-cell process. Courtesy Dr. Edward Lee, Washington, D.C. Chapter 32 Gastrointestinal Lymphomas 455 32 CD2+, CD5, CD4, CD8+, CD30+, CD103+, and contain cytotoxic granules recognized by the antibody TIA 1.190. Monoclonal T-cell populations can also be detected in mucosa not involved by lymphoma. Whole genome analysis and HLA genotyping has identified two subtypes of EATL. 191 type I is CD56 negative, pathogenically linked to celiac disease, and shares an HLA-1 genotype pattern with refractory celiac disease. Mitral, previously type 2 EATL, is CD56+, MYC+, and shows an HLA-DQB1 genotype pattern like that of the normal Caucasian population. Clinical features: patients may have a history of documented celiac disease, with the time to development of lymphoma varying widely. However, at least half of patients have celiac sprue diagnosed at the same time as the lymphoma. The most common symptoms at presentation are abdominal pain, weight loss, diarrhea, or vomiting. Less common symptoms may include fever, night sweats, and small bowel obstruction or perforation. It is rare for patients to have palpable abdominal masses or peripheral lymphadenopathy, but extra-intestinal sites of involvement may include the liver, spleen, thyroid, skin, nasal sinus, and brain. 165 in 1 series, beta-2 microglobulin and serum LDH were elevated in 85.7% and 62% of patients, respectively, and anemia and low serum albumin levels were seen in 91% and 88% of patients, respectively. 192 Diagnosis is usually made by endoscopic biopsies or full-thickness, laparoscopic small bowel biopsies. Traditionally, patients were staged with CT and bone marrow biopsies, but 18-FFDG PET-CT appears to be more sensitive and specific than CT in differentiating EATL from refractory celiac disease. 193 The Lugano system been proposed as a staging system, but its utility in assessing prognosis is unclear. 55 Treatment: no large controlled trials of therapy for EATL have been reported. Thus, standard treatment is not well defined. Typically, patients are treated with a combination of surgery and chemotherapy. 192 Surgery involves removal of as much tumor as is feasible. Intensive chemotherapy is then administered postoperatively, with the most common regimens being ones that contain anthracyclines such as CHOP in older adults and CHOP with etoposide in younger adults. 174 The 5-year overall survival rate with anthracycline-based chemotherapy alone is approximately 10% to 20%. For this reason, and based on retrospective data, most experts recommend an autologous stem cell transplant in first remission for the more robust patients with no or minimal medical comorbidities. Nutritional status is commonly poor, requiring parenteral nutrition. Because of poor nutritional and performance status, less than 50% of patients are candidates for systemic chemotherapy, and of those, less than 50% can complete the prescribed treatment regimen. Relapse occurs at a median of 6 months from the time of diagnosis in approximately 80% of patients, usually in small bowel sites. Various salvage regimens have been tried for patients with relapsed disease, but few relapsed patients have survived. 194 Poor results with conventional chemotherapy has led to the investigation of high-dose chemotherapy followed by autologous stem cell transplantation in the minority of patients with inadequate performance status. A retrospective study of autologous stem cell transplantation by the European Group for Blood and Marrow Transplantation, including 44 patients transplanted between 2000 and 2010, showed a 4-year relapse incidence, progression-free survival, and overall survival of 39%, 54%, and 59%, respectively. 195 Therapy with novel agents has also been attempted. Alemtuzumab, Campathy, an anti-CD52 monoclonal antibody, has been used to treat refractory celiac disease. 196 As well as brentuximab vedotin, an anti-CD30 monoclonal antibody conjugated to monomethyl-auristatin E, an antimitotic agent. 197 Conceivably, earlier diagnosis may improve the outcome. The diagnosis should be considered for patients who present in midlife with celiac disease and for those who have clinical deterioration after having been stable on a gluten-free diet. Uncommon small intestinal lymphomas: natural killer type T-cell intestinal lymphoma, extranodal NK T-cell lymphoma, nasal type, is a distinct pathologic entity in the WHO classification of hematolymphoid malignancies. 5 Very rare cases of intestinal NK cell lymphomas have been described. 198 Most of the cases reported have not involved patients with celiac sprue or sensitivity to gluten. 120,121 Optimal management of this very rare disorder has not been determined. Most data come from East Asian countries, and traditional regimens such as CHOP and CHOEP have high treatment failure rates. Aggressive regimens such as DVIC, dexamethasone, etoposide, ifosfamide, carboplatin, and SMILE, dexamethasone, methotrexate, ifosfamide, L-asparaginase, etoposide, with and without radiation, have been used with some degree of success. Immunotherapy with anti-PD-1 checkpoint inhibitors such as pembrolizumab is showing promising responses in the relapsed/refractory subset of patients with this disease entity. 199 Other gastrointestinal sites. NHL less commonly occurs in other sites of the GI tract, including the oropharynx, esophagus, liver, pancreas, biliary tree, appendix, colon, and rectum. Signs and symptoms reflect the site of presentation. Because of the relative rarity of these disorders, literature is fairly limited. Therefore, definitive conclusions cannot be reached about the optimal management of these more unusual GI lymphomas. Standard principles of lymphoma management dictate diagnostic procedures, staging, prognostic assessment, and treatment. As is the case for all lymphomas, histology and stage guide treatment. Waldie-Ring lymphomas are usually diffuse large cell lymphomas, but other histologies may be present instead. 200,201 Endoscopy and imaging of the remainder of the GI tract should be included in the staging workup, because lymphoma 2 involvement in other sites may accompany Waldie-Ring involvement. Ann Arbor stage I or II diffuse large cell lymphoma is managed with combined anthracycline-based chemotherapy and/or local radiotherapy. 106 Primary hepatic lymphoma is more common in men and has a median age of onset of approximately 50 years. 202,203 Primary hepatic lymphoma can present as a single, large, multilobulated mass or as single or multiple nodules. The histology is usually diffuse large B-cell, but MALT lymphoma, extranodal marginal B-cell lymphoma, has been reported as well. Rare cases of T-cell hepatic lymphoma have been reported. Diagnosis is usually made by needle biopsy. Because of the rarity of the disease, optimal therapy is uncertain. Long-term disease-free survival has been reported after resection, but multi-agent chemoimmunotherapy is probably most appropriate for DLBCL. Less aggressive chemoimmunotherapy or single-agent rituximab may be appropriate for lymphomas with marginal zone histology. An association of HCV with hepatic and splenic marginal zone lymphoma has been established, and response of the lymphoma to hepatitis C treatment has been documented. 204,205, whether there may be an association with other hepatitis viruses and hepatic lymphomas is unknown. Pancreatic lymphomas are rare. 0.5% of all pancreatic tumors, 0.206 patients have a clinical presentation similar to that of pancreatic adenocarcinoma, with abdominal pain and obstructive jaundice. Chylocystitis have also been reported. Histology 456 Part 4 Topics involving multiple organs is diffuse large B-cell in over 80% of the cases, and published literature supports use of combined modality therapy with anthracycline-containing chemotherapy, e.g., CHOP, with rituximab along with radiation. Patients with biliary obstruction may require a biliary drainage procedure before being treated with chemotherapy to avoid excessive chemotherapy-related toxicity. Primary colorectal lymphomas most commonly involve the cecum 207,208 with high or intermediate grade histology. Most colorectal lymphomas are Ann Arbor stage IE or IIE. Therapy is dictated by histology and stage. Resection is the standard therapy, with adjuvant chemotherapy given for patients with aggressive histology. Immunodeficiency-related lymphomas. Post-transplantation lymphoproliferative disorders. The post-transplantation lymphoproliferative disorders, PTLDs, 209,211 complicate 0.8% to 20% of cases of those with solid organ transplants, see Chapter 36, with the incidence being highest in heart-lung transplant recipients. PTLDs are also seen in bone marrow transplant recipients, particularly in patients receiving T-cell depleted allografts. PTLD results from proliferation of Epstein-Barr virus, EBV, transformed B-cell clones that have developed in part because of immunosuppression. 212 The histologic appearance of PTLD is highly variable, with lesions being polymorphic or monomorphic, resembling a lymphoma. The histology may reflect infectious mononucleosis, aggressive NHL, or plasmacytoma. Lesions may be polyclonal, oligoclonal, or monoclonal. Monoclonal lesions, similar in appearance to low-grade lymphomas such as FL, marginal zone lymphoma, small lymphocytic lymphomas, by convention, are not considered PTLD. The clinical presentation also varies greatly, with some patients having a syndrome resembling infectious mononucleosis and some having a more lymphoma-like presentation, with nodal or extranodal disease. Involvement of extranodal areas is common, with the GI tract being a common site. The literature regarding the treatment of PTLD suffers from a lack of prospective trials and lack of standardized histologic classification. The treatment approach varies, but usually consists initially of withdrawal/modulation of immunosuppression for polymorphic PTLD. 213 for monomorphic PTLD, that is CD20+, in addition to minimizing immunosuppression, the preferred treatment is immunotherapy with the anti-CD20 antibody rituximab or subsequently, combining it with an anthracycline-based chemotherapy for patients who fail to respond to this first maneuver. This sequential approach to treatment is based predominantly on European data which supports long-term disease-free survival in early responders to rituximab therapy, thereby avoiding the need for toxic chemotherapeutics altogether in patients with CD20 positive PTLD. 214 Surgical or radiation therapy may cure patients with localized disease in highly selected cases. Other treatments have included acyclovir or ganciclovir directed at EBV, allogeneic cytotoxic EBV-specific T cells or EBV-CTL, and interferon alpha donor leukocyte infusions are frequently used for patients with PTLD that develops after allogeneic bone marrow transplantation. 215 Iatrogenic lymphoproliferative disorders. Increasingly, a spectrum of lymphoproliferative conditions is being recognized and described in the setting of use of immunosuppressive drugs outside the setting of transplant. Other iatrogenic immunodeficiency-associated lymphoproliferative disorders, OIIALPDS, 216 methotrexate-driven lymphomas have been well recognized and described. We are increasingly seeing patients with IBD, on or with a history of immune suppression, including biologics such as TNF inhibitors, present with these conditions. EBV is a central driving force behind many of these conditions, and management is extrapolated from the PTLD literature. See section on post-transplantation lymphoproliferative disorders. Polymorphic lymphoproliferation is thought to be reactive and predominantly treated with withdrawing immunosuppression. Monomorphic lymphoproliferation can resemble any NHL or Hodgkin lymphoma, and treatment is based predominantly on grade, type, and extent of lymphoma at the time of presentation. At our institution, we favor close observation after stopping immunosuppression for patients with low-grade disease and a low tumor burden if possible. Spontaneous regression can be seen in as many as 40% of these patients. Upfront chemotherapy is generally offered to patients with a high-grade lymphoma in the setting of extensive organ involvement or visceral crisis. The WHO 2016 classification has a provisional entry of a unique disorder, generally affecting older adults, called EBV-positive mucocutaneous ulcer that has some pathologic features of Hodgkin lymphoma, Fig 32.10. This disease is often seen in the setting of immune suppression, and predominantly presents as well-circumscribed oropharyngeal lesions but can involve skin and any site along the length of the GI tract. These lesions EBV/EBER CD30AB. Dr. Veena Chen, UT Southwestern Medical Center, Dallas, TX. Abundant cytoplasm, variably resembling Hodgkin cells that express EBV/EBER and CD30, insets. Courtesy bowel mucosa with ulceration. B. Shows large lymphoid cells with irregular nucleus, prominent nucleolus, and polymorphous infiltrate including small lymphocytes, histiocytes, and large atypical lymphoid cells in small. Fig 32.10 photomicrograph showing EBV-positive mucocutaneous ulcer in the small bowel. A. Shows a Chapter 32 gastrointestinal lymphomas. 457-32 predominantly have an indolent course, 45% spontaneous remission, 15% relapsing/remitting course, and clinico-pathologic correlation is important to distinguish this from Hodgkin lymphoma, which seldom presents with extranodal involvement. 217 HIV-associated non-Hodgkin lymphoma. The risk of developing NHL is markedly increased in patients with HIV, see Chapter 35, and development of lymphoma is considered an AIDS-defining condition. These malignancies are B-cell neoplasms 218, with most cases having small non-cleaved cell or diffuse large cell histology. EBV is implicated in about half of non-central nervous system HIV-related lymphomas. HIV-associated NHL typically has an aggressive presentation, with rapidly growing disease and prominent B symptoms. The GI tract is a common site, including unusual sites such as the anus and rectum. Historically, chemotherapy has been poorly tolerated and lower-dose chemotherapy regimens have been used. However, patients with higher CD4+ T cell counts, as is more commonly seen in view of the standard current usage of HAART, may be better able to tolerate full-dose chemotherapy regimens and may have a better prognosis than has been seen in previous studies. 219 Plasmablastic lymphoma, PBL, an aggressive variant of DLBCL, was initially described in the oral cavity in HIV patients. Most GI PBL cases involve the anal canal in HIV-infected patients. PBL is essentially negative for CD20, CD45, and PAX5 and expresses plasma cell-associated proteins, including CD38, CD138, and VS38C. The majority of cases are EBV positive and HHV8 negative. MYC rearrangements are detected frequently, Fig 32.11. Aggressive chemoimmunotherapy strategies such as V-EPIC bortezomib, Velcade, with EPIC are showing promising responses in this difficult-to-treat disorder. 220 Primary effusion lymphoma is a clinicopathologic entity associated with the herpes virus HHV8, Kaposi sarcoma-associated virus. 221,222 Histology shows a distinctive morphology that bridges large cell immunoblastic lymphoma and anaplastic large cell lymphoma. 223 Tumor cells show monoclonal immunoglobulin gene rearrangements but typically lack B-cell associated antigens. HHV8 is detectable by PCR assay. Patients are usually HIV positive, but the syndrome has been reported in HIV-negative patients. Patients present with malignant effusions in the pleural or peritoneal cavity, which remain localized to the body cavity of origin. Disease progression is rapid, with survival of only a few weeks to months. Optimal therapy has not been defined.